Good afternoon, everybody. In today's class, we'll discuss about the prostate gland. As you know, the prostate is an accessory gland of the male reproductive system. Its secretions add bulk to the seminal fluid, and embryologically, it is represented in the female by certain type of glands which are termed as the paraurethral glands or the Skinner's glands. The specific learning objectives of a prostate gland are 1. Location, 2. External features and relations. Also in this objective, we'll be discussing the parts, the surfaces and their relation. Third one is the lobes of the prostate gland. Fourth is the structure of the prostate, and along with we'll be studying the zones of the prostate gland also, which is a relatively newer concept. Then we'll be seeing the structures which are present within the prostate gland, the coverings or the capsules of the prostate, the supports of the prostate gland, the blood supply, that means the arterial supply, the venous drainage and the lymphatics. We'll be stressing a little bit on the venous drainage again because of its clinical relevance. Then we'll be seeing the age related changes in the prostate gland, and finally the important clinical anatomy, in which we'll be discussing about the two most common clinical conditions that affect the prostate gland, namely the benign prostatic hypertrophy or BPH and prostatic carcinoma. The prostate is a pyramidal shaped fibromuscular glandular organ which surrounds the prostatic urethra, which extends from the base of the urinary bladder up to the membranous urethra, and it lies in front of the rectal ampulla. So the prostate is a pyramidal shaped fibromuscular gland which surrounds the prostatic part of urethra and extends from the bladder base to the membranous urethra, and it lies in front of the rectal ampulla. Coming to the location of the prostate gland, the prostate gland is located in the lesser pelvis, below the neck of the urinary bladder and above the urogenital diaphragm. It lies behind the lower part of the pubic symphysis, and we have seen already in front of the rectal ampulla, and it is embraced or covered on each side by the levator and a muscle. So the key points to note regarding the location of the prostate gland, that it is located in the lesser pelvis, below the neck of the urinary bladder and above the urogenital diaphragm. That means between the neck of the urinary bladder and the urogenital diaphragm, and it corresponds to the lower part of the pubic symphysis, and it is related on both sides with the levator and a muscle. We will see the external features and the relations of the prostate gland, and this might be of importance from your theory exam point of view. The prostate presents the following external features. It has an apex, a base and 4 surfaces. The 4 surfaces are anterior, posterior and 2 infralateral surfaces. Once again, the prostate gland presents an apex, a base and 4 surfaces: anterior surface, posterior surface and 2 infralateral surfaces. First, we will take up the relations of the apex and base of the prostate gland. The apex of the prostate gland is directed downwards and rests on the superior surface of the urogenital diaphragm. Please try to revise the urogenital diaphragm. So the apex directed downwards and rests on the superior surface of the urogenital diaphragm. The base is much more important. It is directed upwards and surrounds the neck of the urinary bladder, with which it is continuous structurally. So the base is directed upwards and surrounds the neck of the urinary bladder. An important point to note regarding the base is that the base is pierced by the urethra almost in the median plane at the junction of the anterior 1/3 and posterior 2/3. So the urethra, which is a continuation of the neck of the urinary bladder, passes through the base of the prostate gland in the median plane at the junction of the anterior 1/3 and the posterior 2/3. Now we'll see the relations of the surfaces. First we'll take up the relations of the anterior surface. The anterior surface is somewhat narrow and convex from side to side. It is located about 2 centimeters behind the pubic symphysis. And the anterior surface is separated from the pubic symphysis by the retropubic space. The retropubic space is also called as the space of Retzius, which is filled with the extraperitoneal fat. The upper part of the anterior surface of the prostate is attached to the symphysis pubis by the puboprostatic ligaments. Coming to the relations of the posterior surface, which is very important. The posterior surface is somewhat broader and flat and lies in front of the ampulla of the rectum, from which it is separated by a fascia called as the fascia of Bilious. So the posterior surface lies just in front of the rectal ampulla, and the posterior surface of the prostate is separated from the rectal ampulla by the fascia of Bilious. The posterior surface is divided into a small upper part and a large lower part by a transverse sulcus, which is pierced on each side of the median plane by the ejaculatory duct. The upper area represents the median lobe, and the lower area is divided again by a median sulcus into the 2 lateral lobes. So the key points to note regarding the posterior surface, its relation to the rectal ampulla, being separated from it by the fascia of Bilious, and also its relation to the ejaculatory ducts. We'll see a little more regarding the Bilious fascia. The Bilious fascia is a dense condensation of the pelvic fascia, and this important surgical layer separates the posterior surface of the prostate, the seminal vesicles, and the ampullae of the vasa deferentia from the rectum. So the Bilious fascia is a thick condensation of the pelvic fascia which separates the posterior surface of the prostate gland, the seminal vesicles, and the ampullae of the vasa deferentia from the rectum. The surgical importance of the Bilious fascia, we'll discuss it later. Coming to the relations of the 2 infralateral surfaces. The 2 infralateral surfaces of the prostate gland are related to the side walls of the pelvis, and they are also related to the anterior fibers of the levator ani muscle. So the infralateral surfaces face the side walls of the pelvis and are related to the levator ani muscles. An important point to note here is that the anterior fibers of levator ani enclose the prostate gland in the pubourethral sling. the anterior fibers of levator ana form the pubo-urethral sling. Next important objective is about the coverings or the capsules of the prostate gland. The prostate capsules are two in number in the normal gland. The first one is the true capsule, which is formed by the condensation of the peripheral fibrous stroma of the gland, and hence this is very intimately related to the gland. So the true capsule is formed by the condensation of the fibrous tissue and is very closely related to the gland. External to this, you can find the false capsule, also called as the prostatic sheath. The false capsule is derived from the pelvic fascia. It lies outside the true capsule and envelops the prostate gland and urinary bladder in the same compartment. So, the external to the true capsule, you can see the false capsule, which is derived from the pelvic fascia, and it envelopes the prostate gland and the urinary bladder in the same compartment. An important clinical correlation in this regard is that the prostatic plexus of veins lies between the two capsules. The prostatic plexus of veins lies between the true capsule and the false capsule. Next important theory objective is the lobes of the prostate gland. The prostate gland is divided into 5 lobes. These are the anterior lobe, which is also called as the isthmus, the posterior lobe, the median lobe, and 2 lateral lobes. So the prostate is divided into 5 lobes: anterior lobe or isthmus, posterior lobe, median or the middle lobe, and 2 lateral lobes. We'll see a little more about the lobes. The anterior lobe lies in front of the urethra and connects the 2 lateral lobes. It is devoid of any glandular tissue and therefore called as the isthmus. The anterior lobe lies in front of the urethra and connects the 2 lateral lobes. Because it is devoid of any glandular tissue, it is called as the isthmus. The posterior lobe, as the name suggests, lies behind the ejaculatory ducts and the median lobe and connects the 2 lateral lobes. The surgical importance of the posterior lobe is that the carcinoma of the prostate gland usually begins in this lobe. The median lobe is otherwise called as the middle lobe. It is a wedge-shaped and lies behind the upper part of the urethra and in front of the ejaculatory ducts. Its base produces an elevation at the apex of the trigonum vesicae, which is called as the uvula vesicae. The median lobe normally projects into the prostatic urethra, causing a bulge or a ridge, which is called as a urethral crest. The median lobe consists much of the glandular tissue and is a common site of adenoma of the prostate gland. So the median lobe is wedge-shaped, lies behind the upper part of the urethra and in front of the ejaculatory ducts. Its base produces an elevation at the apex of the trigone of the urinary bladder, which is termed as the uvula vesicae. And the median lobe also projects into the prostatic urethra, rising a ridge called as the urethral crest. And histologically, it contains most of the glandular tissue of the prostate. The 2 lateral lobes lie on each side of the urethra. On the posterior surface of the prostate, the 2 lateral lobes are separated from each other by the posterior median sulcus. The lateral lobes contain some amount of glandular tissue and therefore adenoma of the prostate gland may also arise from the lateral lobes. So from the clinical point of view, the posterior lobe is important because it's a common site of the carcinoma of the prostate gland, whereas the median lobe is the common site for an adenoma of the prostate gland. Next important objective is the structure of the prostate gland, in which we also see the zones of the prostate gland. As you may have already studied in the histology class, the prostate is made up of fibrous tissue, muscular tissue, and glandular tissue. The fibrous tissue constitutes about 1/4, the muscular tissue 1/4, and the glandular tissue makes up the remaining half. The glandular tissue consists of tubulo-alveolar glands, which are arranged in 3 concentric groups. All of this open into the urethra. The fibromuscular tissue forms the stroma, and the glandular tissue forms the parenchyma of the prostate gland. And the lumen of these tubulo-alveolar glands contains small colloid masses, which are termed as the corpora amblytia. Now we'll see the zones of the prostate gland. The prostate gland is histologically divided into 3 zones. So actually it is a glandular tissue of the prostate gland which is divided into the 3 zones. So you get a peripheral zone which constitutes about 70% and is located posteriorly in relation to the rectum, and it forms the main body of the glands. Embryologically, it is derived from the urogenital sinus. The central zone occupies around 25% and surrounds the ejaculatory duct, and embryologically it is derived from the mesonephric duct. And the transitional zone constitutes about 5% and it surrounds the urethra, and embryologically it is derived from the urogenital sinus, and this transitional zone is located centrally. So the new concept regarding the zones of the prostate gland, that the glandular tissue is divided into 3 zones, namely the peripheral, central, and transitional. These zones are of clinical importance because the most common disease that affects the prostate gland, especially in older men, is benign prostatic hypertrophy. And this benign prostatic hypertrophy particularly affects the transition zone. And this transition zone will be enlarged markedly in this particular clinical condition. The peripheral zone is exclusively the site of carcinoma of the prostate. Next important objective is the structures within the prostate gland. The prostate gland presents 3 important structures inside it: the prostatic urethra, the prostatic utricle, and the ejaculatory ducts. The prostatic urethra traverses vertically downwards through the gland at the junction of the anterior 1/3 and posterior 2/3 and opens on the anterior surface just above the apex. So the most important structure which is present within the prostate gland is the prostatic part of urethra. The prostatic part of the urethra traverses or passes vertically downwards through the gland, lying at the junction of the anterior 1/3 and the posterior 2/3. The second structure which is present inside the prostate gland is the prostatic utricle. The prostatic utricle is a mucous blind sac or cul-de-sac about 6 mm long. This extends upwards and backwards from the prostatic urethra behind the median lobe. And the third important structure which is present within the prostate gland are the ejaculatory ducts. The ejaculatory ducts traverse the gland posterolateral to the median lobe and open into the urethra. So, the three structures within the prostate are the prostatic urethra, the prostatic utricle, and the ejaculatory ducts. Coming to the supports of the prostate gland. There are three major supports for the prostate gland: the urogenital diaphragm, the puboprostatic ligaments, and the fascia of Deno Bilious. Out of this, the most important, of course, is the urogenital diaphragm. As we have seen already, the apex of the prostate gland rests on the urogenital diaphragm, and the prostatic sheath, that is a false capsule, is continuous with the superior fascia of the urogenital diaphragm. The second is the puboprostatic ligaments. These two pairs of ligaments extend from the prostatic sheath, that's the false capsule, to the back of the pubic bones. The medial pair of the puboprostatic ligaments lie near the apex of the gland, whereas the lateral pair lie close to the base. So, you can see the two pairs of puboprostatic ligaments that extend from the prostatic sheath to the posterior surface of the pubic bones. And the third support is the fascia of Deno Bilious, also termed as the rectovesical fascia. The posterior aspect of the prostatic sheath adheres to this fascia posteriorly. So once again, the three supports of the prostate gland are the urogenital diaphragm, which is the most important one, the two pairs of puboprostatic ligaments, and the rectovesical fascia or the fascia of Deno Bilious. We will take up the next objective, that is the blood vessels and lymphatics of the prostate gland. The arterial supply of the prostate gland comes from three arteries, mainly the inferior vesicle, middle rectal, and the internal pudendal arteries. All these are branches of the internal iliac artery, which is a chief artery of the pelvis. So the major arterial supply comes from the first two, namely the inferior vesicle and the middle rectal. We'll see the venous drainage in a little bit detail because it is clinically important. The veins from the prostate forms a rich venous plexus, especially around the sides and the base of the gland. And as we have discussed already, the veins occupy the space between the true and the false capsules. It receives the deep dorsal vein of the penis in the front and it's continuous above with the vesical venous plexus of the bladder. The mode of venous drainage from the prostate follows two pathways. One, the drains into the internal iliac veins through the posterior ligaments of the urinary bladder. And second, it may drain into the internal and the external vertebral venous plexus through the veins passing through the anterior sacral foramina. The communication between the vesicle and the vertebral venous plexus is devoid of any valves. So, to repeat, the venous drainage can follow two pathways. Usually, it drains into the internal iliac veins through the posterior ligaments of the urinary bladder. The venous blood can also drain into the internal and the external vertebral venous plexus, and these plexus are termed as the Batsen's plexus, which are studied along with the vertebral canal, and this occurs via veins passing through the anterior sacral foramina. The clinical importance of this drainage is that the communication between the vesicle and the vertebral venous plexus is devoid of any valves. Lymphatics of the prostate, they drain into the internal and the external iliac nodes. So that's about the arterial supply, the venous drainage and the lymphatic drainage. To the last but one objective, the changes in the prostate gland with age. The prostate exhibits drastic age-related changes. In the childhood, the prostate gland is relatively small and is composed mainly of fibromuscular stroma and rudiments of the ducts. During puberty, there is a sudden increase in the size of the gland under the influence of the male hormones, especially testosterone. It becomes double of its pre-pubertal size. And there is also a rapid proliferation of the prostatic follicles which starts secretion. And during the third decade, there are irregular epithelial infoldings in the lumen of the follicles and making them somewhat irregular in shape. And during the fourth decade, the size of the prostate remains constant. The epithelial infoldings into the lumen gradually disappear and amyloid concretions, or otherwise called as the amyloid bodies, appear within the follicles. And from the fifth decade, that is after 50 years of age, some degree of prostatic hypertrophy is invariably present. So it is considered as a sign of aging, just like the graying of your hair. So the major age-related changes to the prostate gland occur at puberty and after the fifth decade of life. Coming to the clinical anatomy of the prostate gland, the two most common diseases that affect the prostate gland is one, benign prostatic hyperplasia or BPH, and the second one is prostate cancer. First we will take up benign prostatic hyperplasia, also termed as benign prostatic hypertrophy. There is an invariable enlargement in the size of the prostate gland in males above 50 years of age. This hypertrophy or hyperplasia typically affects the median lobe of the prostate gland. So the benign prostatic hyperplasia or hypertrophy commonly involves the median lobe, which in turn leads to compression of the prostatic urethra and obstruction to the urine flow. Clinically, benign prostatic hyperplasia presents as an increased frequency of urination, an urgency of urination, difficulty in the starting and the stopping of urination, and also a sense of incomplete emptying of the urinary bladder. So the four cardinal symptoms of BPH, one is an increased frequency of urination, urgency of urination, difficulty in starting and stopping the flow of urine, and also a sense of incomplete emptying of the urinary bladder. According to the new concepts, the benign prostatic hyperplasia involves the central zone of the prostate gland. So in this regard, try to recap regarding the zones of the prostate gland. And a surgical removal of this adenoma or a hypertrophy is called prostatectomy. There are several surgical approaches in prostatectomy or surgical removal of the prostate gland. It can be a suprapubic approach, a retropubic approach, or perineal or a transurethral approach. A transurethral approach is the most commonly used technique in prostatectomy or a surgical removal of the prostate gland. Coming to prostatic cancer or prostatic carcinoma, it also usually occurs after the age of 50 years. The carcinoma is commonly found in the peripheral or the outer zone, which usually involves the posterior lobe. Clinically, it presents as a pain in the perineal region, urinary obstruction, and also difficulty in urination. For diagnosis of a prostatic carcinoma, a per-rectal examination is done, and a per-rectal examination usually reveals irregular hard fixed prostate and absence of the median groove on the posterior surface of the prostate gland. The serum levels of acid phosphatase and prostate-specific antigens are also used in the diagnosis and the management of the prostate cancer. One important point to note regarding the spread of prostate cancer is that the metastasis of the prostatic carcinoma, that is the spread of the cancer cells from the primary carcinoma, commonly occurs in the lumbar vertebrae and in the pelvis because of the venous drainage carries these metastatic deposits from the prostate gland through the vertebral venous plexus to the lumbar vertebrae and also to the pelvis. Before concluding, we'll see what are the important questions you are likely to get regarding the prostate gland. Of course, prostate is a PBL based long essay question of 15 marks. The subdivisions of this long essay usually relates to the following points. The external features, that means the parts, the apex, base, the surfaces and their relations, the lobes of the prostate gland, the histological structure and the structural zones, the capsules or the coverings of the prostate gland along with the clinical importance, the structures present within the prostate gland, and finally the blood supply, in which you have to know a little bit in detail regarding the venous drainage of the prostate gland and its significance in relation to the spread of prostatic cancer. Thank you. Have a nice day.